It is my pleasure to introduce our own David Cooke, who is, as you know, the chief of thoracic surgery here, also recently taken on the role as the interim physician in chief for the Comprehensive Cancer Center. He's going to talk to us today about something really important and something important for all of you to think about, which is the changing approach in many environments to how our activity is organized, and what are some of the pros and cons and benefits there. I mean, that's the integrated service line. Of course, one integrated service line is just like one marriage. You know, they're all particularly unique and nuanced. But this is something that is happening at our institution right now, and I think the lung cancer service line is the first.
Yep.
So this really gives us an opportunity to take away some lessons from that. So with that, Dr. Cooke, thank you
Great.
very much.
Thank you. Thank you, Dr. Farmer. Today I'll talk about our UC Davis Lung Cancer Integrative Service Line, or ISL. What is it and how can it save lives? I like dramatic titles to wake people up. I have no disclosures. So lung cancer kills more men and women than breast cancer, prostate cancer, and colon cancer combined. I think many of us have seen this data so far. In the 2023, the most recent American Lung Association State of Lung Cancer report, close to 240,000 people will be diagnosed with lung cancer this year, with new cases varying by state. And lung cancer is one of the lowest 5-year survival rates of all solid organ tumors, with the average 5-year survival being about 27%. And only about 25 to 27% of cases diagnosed in the United States are diagnosed at an early stage. So about 75% of cases are diagnosed at stage 3 or stage 4, which obviously is the most difficult to cure. 80% of lung cancer is caused by smoking. And unfortunately, lung cancer is one of those stigma cancers that doesn't get sort of like the nice, air about it, the annual yearly attention, or football players wearing cleats about it. And a lot of it is because it's associated with smoking, and it's considered by many, including many of us, meaning people within the house of healthcare, as a lifestyle disease. You chose to smoke, and now you have lung cancer. But unfortunately, that doesn't take into consideration targeted marketing by the tobacco industry to get people to start smoking, or to get our young people to start vaping so they can transition to combustible tobacco. And it doesn't take into consideration that nicotine is more addictive than heroin. But it's not just a smoking disease. So 20% of lung cancer is caused by something other than smoking. That includes radon exposure. That includes air pollution. More people are diagnosed with lung cancer in Beijing than the United States every year, and is recognized by the World Health Organization, air pollution, as a cause of lung cancer. It's also caused by bad luck, which is layman's term for genetics. So lung cancer is the leading cause of cancer and mortality amongst Asian American populations. And many of these individuals who are stricken with lung cancer are never smokers. So people who don't have a significant smoking history, and those who don't have a significant secondhand smoke. And we have an issue when we care for patients with lung cancer in the United States. We have delays in treatment. There's a delay of lung cancer treatment beyond 90 days from diagnosis negatively impacts survival. Each week of delay confers a 4% risk of death. In a recent survey by ASCO, 90% of providers reported insurance delays in imaging and referral to specialists, and 30% of those providers felt that their patients were harmed because of those insurance delays. So pre-authorization and that such. And in the National Cancer Database from the ACS, review initiated adjuvant chemotherapy after surgery within 50 days is associated with improved survival. So we have lung cancer, which is the biggest cancer killer in the United States. but we have a complex interactions within our healthcare system of different equally important parts: surgery, medical oncology, radiation oncology, clinical trials, molecular testing. And those, the lack of connectivity with those different nodes leads to poor outcomes and delays. And we see this in the state of California. And we see this if you have a problem in any system, then you add on to that system disparities. And we see this in the state of California. In a recent analysis of our California Cancer Registry, when compared to white Californians, Black and African American patients were more likely to be diagnosed at a late stage disease. And this late stage of diagnosis for cancer occurred in the 6 screen detectable cancers. So breast cancer, cervical cancer, colorectal cancer, prostate cancer, and lung cancer. So a significantly higher percentage of Black African Americans versus white patients with lung cancer and other cancers were diagnosed at a later stage. And then if you look at the entire United States, again, from the American Lung Association, across demographics, there are about 30% of patients in the United States don't get any type of treatment for lung cancer. So that's ranging from 20 to 26%. And about 17 to 25% of patients who could benefit from surgery don't get any surgery at all. And it's not surprising that our survival rate is less than 30%. And then this is a picture of healthcare in general. So this is looking at the price changes in consumer goods and services in the United States from 1997 to 2023. I don't know if you're old enough to remember what a big deal to have a TV in your house. It was such a big deal that it came encased in wood, so it kind of fit the furniture around the house. Now you have a TV basically on your phone. The cost of televisions have dropped. Here's the cost of healthcare in the United States, which markedly outpaces inflation. And then just for your medical students out there, this is tuition, school fees, college tuition, and fees. I don't know if you saw the most recent episode of Saturday Night Live, but Keenan played a parent of a student at Columbia, and he in the skit he stated, and they were out there protesting, and they said we need freedom. You know what's not free? Columbia. So here I have a question. So based on that data, and based on the challenges in the treatment of lung cancer, and the challenges that all of you face when dealing with restoring the health of your patients, raise your hand if you feel in some ways our healthcare system is broken. Now, raise your hand if you feel our health system is not providing proper value to our patients. Now, raise your hand if you had a loved one or a family member who is stricken ill, you would advise them to leave the country to get their care. Yeah. So I think we always are. I won't say who raised their hand. I'm able to see from this angle. We're always very morose about our surroundings and our environment. But the reality is that we have some of the best healthcare in the world when you look at individual components and individual nodes. So we've actually had a decline in the death rate from lung cancer in the United States. So if you look at cancer statistics, 2024, published by the Journal of the American Cancer Society, lung cancer mortality decline accelerated from 2% per year during the period of 2005 to 13 to 4% per year during the most recent period up to 2021. The lung cancer death rate has dropped by 59% from the peak in men in 1990 and by 36% from the peak in women in 2002. And we talked about the disparities in healthcare in the United States and California, but actually there have been improvements in all demographics. So you look at cancer mortality rates from Black and African American men declined by 2.3% per year for all cancers combined. And then among Black and African American women, it dropped by 2.1% per year. So why is that? So one is population health. Um, and it's interesting. I think when I submitted my slides, somehow they got um, uh, jumbled. But just like Clinton in the State of the Union address, I'll just go by the top of my head. Um, so why have we shown improvements in cancer survival? One is radon awareness, tobacco recovery and prevention, lung cancer screening, which we'll talk about, advances in surgery, stereotactic body radiotherapy, precision medicine and immunotherapy, and patient activation. So, thank you, Siri. So, what is the issue? So, right now, we have different nodes um, that have that express high value, but they're not connected. So this picture on the right are what are called free-floating planets. So these are planets not connected to a sun. They have no gravity. They're just out floating out there in the universe with no gravity sort of connecting them and no solar system. So what we are hoping to deal with that, sorry, my slides got mumbled up, is to take what we have and do well at UC Davis and provide that sort of gravity and connection and cohesion. And a way to do that was to develop what's called integrated service lines. So UC Davis Health in 2022 and 2027 created a clinical strategic plan. And part of that plan was to create what are called integrated service lines. So what are integrated service lines? So a service line is just a clinical group that treats a disease process. So thoracic surgery is a service line. A multidisciplinary team are different service lines working together. An integrated service line is somehow those multidisciplinary teams being integrated in a way, having a formal gravity, a intersection, if you will. So integrated service line is an organization of multidisciplinary clinical teams integrating a care continuum around a population or disease state. There's a sense of accountability, responsibility for optimizing clinical services. A, uh, a service line structure is intended to provide a more integrated and focused patient experience. This is ideally patient-centered or human-centered. So it provides care with the top priority on making all decisions centered around the people we serve today. Of course, cultural competence is baked in with that, and the observation is that we as an academic medical center are all part of a community. There's a culture of innovation, which includes clinical trials, new technology, minimally invasive procedures. And the key here is access. Patients need to be seen sooner. There's decreased provider referrals, wait time, and then taking what we've learned from COVID-19, utilizing virtual care to improve that access. And how can we improve our electronic health record for that access? And then care coordination with patient navigation, utilizing our interdisciplinary teams, and visits as soon as possible. So this is what we saw as the pre-ISL state for lung cancer care at UC Davis Health. So this is James, and he's seeing his primary care provider for his annual exam. James quit smoking 10 years ago. He has a 30-pack year smoking history, and he's 55 years old. So all those, the thoracic surgical residents, I hope someone raises their hand and answers this correctly. What should James get? Devin, you should get what? Why? He's at risk for lung cancer with this history. So age 50 to 80, 20-pack year smoking history, and if the individual has quit within smoking, they quit within 15 years, they are eligible for a lung cancer screening exam with a low dose CT scan. But here, and we will have what are called HEDIS measures to, and we'll talk about this more, to look at our primary care team to see if they're achieving quality by having their patients at risk getting lung cancer screening. But in the pre-ISL state at UC Davis, that was not happening. The next case, Charles is admitted after a rock climbing accident. Gets his bandages up, some fractured ribs, maybe a post-pulmonary pneumothorax or something like that. On his CT scan, he was noticed to have an incidental pulmonary nodule. He gets his fractures mended, and he was sent home. 1 year later, he presents with metastatic lung cancer. Linda has a lung mass. Everything is bewildering to her. She has all these tests that are ordered from different doctors. She doesn't know where to go. And they're taking just a long time. She's asking her daughter to helping her, and even the daughter is confused. And her next appointment is in a month. She gets fed up and goes to UCSF. Sarah's lung cancer free 5 years after surgical resection, but she's terrified of it coming back. Sorry, she's a year after surgical resection. She's doing well, cruise control, 4 more years of surveillance to go, but she's terrified of it coming back, and she wants to see the surgeon who did her operation every 6 months and eventually once a year until she hits that 5-year mark. But because of that, that fills up clinic space, and that diminishes access to other new patients. So this is what we saw as the UC Davis Health pre-ISL space. And so what we did with the assistance of our strategy office at that time, we collected multiple different stakeholders in the patient care continuum for individuals with lung cancer. So again, don't know why these images are muddled up, but here's many of us together. I think I was the one taking the pictures. That's why you don't see me. Many of us together putting up different pain points in the system. And here is a picture of me. I didn't even know that was in there. And looking at patient centricity through journey mapping. But not only did we look at the clinician and staff stakeholders, but we also did focus groups with patients. And we identified with patients their pain points. So we compiled the results of the focus groups to then develop a synthetic patient and identify different pain points and positive points on their journey. So a positive point, I was told about multidisciplinary tumor board and treatment options. When they presented the feedback and recommendations from the tumor board, it provided me confidence in my decision. Here's a pain point. Given education materials and told about palliative care services. Mental health support and just talking about these services has to be done more often. You don't drink from a fire hose when you're talking about your doctor and you don't remember anything about these services. Another positive point, waking up out of surgery and having the doctor tell you we got the cancer is the first time you feel relief. A pain point, getting help for filing for disability was impossible, absolute garbage. The department never followed through with anything. It was so terrible. So how do we go from this, our pre-ISL state, and taking all that information, all that data, and go to this? So this is what our idealized state is. Our lung cancer integrated service line, trust, simple, peace of mind. So James gets a lung cancer screening CT after seeing his primary care provider and finds an early stage lung cancer. Charles's incidental lung cancer is diagnosed at an early stage and he's cured. That's the rock climber. Sorry, I had some really cool graphics here and somehow it got jumbled up. Linda and her family are happy with the speed of her diagnosis and ease of her care. They want to give back to UC Davis, and they talk to our development office. And Sarah's doctor is amazed in how fast her referrals get into UC Davis. I had some key pictures of stakeholders here, and somehow they got jumbled up. But key stakeholders to help put all this together: Jonathan Reese, who is the physician lead of our lung cancer ISL. Chin Fan is the new associate physician lead. I was the former associate physician lead before I took on my current role. Kelsey Ingerselli, who's the current program manager for the lung cancer ISL, and Kristen Minsonides, who is our executive director for the ISL. We're all key stakeholders, and unfortunately, their pictures didn't come up here. So this is the lung cancer ISL, and this is what we view as the ISL care continuum. So there are three phases to the lung cancer ISL. One is a community-based care population health phase, specifically the lung cancer lung nodule early detection clinic, or the lung lead clinic, and we'll talk a little bit about that. It is important in all these priority areas is that we incorporate digital Davis. We have aspirations for artificial intelligence lung nodule detection. In the future, a second opinion program, perhaps mobile screening. Those are all sort of future states. The second phase, the middle part of the continuum, is comprehensive patient navigation and core coordination. How do we take those planets floating in the ether and create a solar system based on gravity? And that's where the care coordination comes in. And then the third phase is surveillance or survivorship, and having a proper survivorship program. So here are the three phases: community-based care, population health. So lung cancer, lung nodule early detection clinic, or the lung lead clinic. Our goal is to increase low-dose CT screening rates of patients with a centralized management of incidental lung nodules, encourage active surveillance of low-dose CT screening patients and incidental findings, and improve upon smoking cessation efforts. So what we want to do is go from this, where 75% of patients in this country are diagnosed at stage 3 and stage 4, with a less than 5% 5-year survival, to this, where 5-year survival after surgery is greater than 80%. So we focused that first phase on lung cancer screening. Many of you know the data. So the National Lung Screening Trial compared low-dose CT scan with chest X-ray with high-risk patients, and what they found was a 20% reduction in lung cancer mortality and a 7% reduction in overall mortality. And then what they also saw was a stage shift. So as we said, about 70 to 75% of patients in the United States are diagnosed at stage 3 or stage 4. In the National Lung Screening Trial, 70 to 75% were diagnosed at stage 1 or stage 2 with the best chance for cure. This study was validated by a large European study called the Nelson Trial. They even lowered the criteria from 55 to 50. These trials, as you know, large multi-institution clinical trials take about 10 years. So the actual technology for low-dose CT scan increased in the interim time period. And also, there's developed a lung rad system similar to BIRADS for breast cancer. And again, my slides are messed up, but what they found was over 30% cancer-specific survival in the intervention arm, and that's comparing low-dose CT versus just best medical management. And so let's talk about disparities. African Americans are more likely to die from lung cancer than white Americans, but African Americans are screened less. African Americans may have a higher incidence of positive screening exams. When detected by screening, African Americans exhibit the same survival advantage and lower stage detection as their white counterparts. So this is one example of an intervention completely wiping out a disparity. If you could get all people to lung cancer screening, then their outcomes are the same. A little bit of slide out of order, but this is the Nelson trial compared to NLST, and again, the markedly favored outcomes. They found a 40 to 60% lung cancer specific mortality in women in the Nelson trial. But that may be a little bit of statistical noise, as their enrollment in women were markedly less than men. So that may be overestimated, but still a greater than 30% lung cancer specific survival. So that's the data for lung cancer. But unfortunately, we are in the midst of a national failure when it comes to lung cancer screening. The American Lung Association surveyed over 1,000 people who were eligible for lung cancer screening, but who did not get lung cancer screening, and they asked them why. Only 15% were aware that lung cancer screening is an essential health benefit and covered by most healthcare plans with no or minimal cost. The top reason why these patients were not screened is they said their doctor never recommended it. And 3% of women cited lung cancer as a relevant health issue, even though lung cancer kills more women in the United States than breast cancer and colon cancer combined. And then the rate of physician to patient discussions about lung cancer is very low and declining. So physicians aren't really talking to their patients about lung cancer screening. So my slides again messed up, but in the United States, less than 5% of patients who are eligible for lung cancer screening get screened. While in the United States, 70% of women who are eligible for breast cancer screening get mammography. And about 60% of Americans who are eligible for colorectal cancer screening get screened in the United States. So 60 to 70% for colorectal and breast, and less than 5% for lung cancer. So it takes about 320 scans to save one life for lung cancer. So if you take the number of Americans who are eligible for lung cancer screening, that 1 in 320 statistic, and you say that all of them got screened at the same rate as women get screened for breast cancer in the United States, how many people would you save? So 2 years ago, the Warriors played the Kings. I'm a Warriors fan, so sorry about that. I guess Kings fans are happy now. So that was actually a 7-game series. So if you took all the people who attended Golden One Center for one game, and you took all the people who attended Chase Center for one game and combined them together, that's how many people, how many lives you would save each year if we had lung cancer screening equivalent to the same rate as other screening tests in the United States. And coming probably by the end of this year, lung cancer screening will be a HEDIS measure. So HEDIS measures are used by private, so commercial payers, to look at quality of care of primary care physicians in their commercial payer plans. So for instance, are you doing diabetes, proper diabetes care? Are you doing proper hypertension care? And lung cancer screening now would be a HEDIS measure, and we would be held accountable for that. So how do we move the needle? How do we get across that finish line of proper lung cancer screening? So this is Dr. Eric Shack, and he did what's called the Clover study. And this was a NIH-funded trial here at UC Davis. And he looked at the use of enhancing electronic health systems to decrease the burden of colon cancer, lung cancer, and other primary care facing disease states. And what Dr. Shack did was, in his intervention, only at the Carmichael PCN site, he looked at lung cancer screening as one of his interventions. And he was able to increase baseline screening adherence at that primary care site from 6% to 19%, which was a 315% increase. And what did he do? So he was able to generate a report from the electronic health record of each patient who fit lung cancer screening criteria, who was about to visit their primary care provider. Then what he did was he had a pre-visit planner, what we now call LVNs, contact those patients ahead of time before reaching their primary care provider and say, this is what lung cancer screening is all about. You are eligible for lung cancer screening. Would you like to speak to our lung cancer screening specialist to undergo shared decision making? Dr. Shack served as that lung cancer screening specialist and then talked to those patients and did what's called shared decision making, which is required for lung cancer screening exam. And then, if they wanted to move forward, sign them up for lung cancer screening. So again, he was able to increase screening rates at that site by 315%. Again, my slides are mixed up, and so this is the authors of that study. So we decided to bake that in to our first priority. So I'm a big believer of rapid bench to bedside. There's no reason for us to recreate the wheel and figure out how are we going to increase lung cancer screening at UC Davis. We had an NIH-funded study that was done here at UC Davis at one PCN that gave us the roadmap. So using Dr. Shack as an advisor, all we did was scaled up what he did. And of course, you would imagine that it's probably not in the best interest to have a MD provide that shared decision making. So those pre-visit planners became LVNs, and our APPs in the cancer center, nurse practitioners, then took the role of Dr. Shack. So again, we used our Epic to flag patients who fit that criteria before they were about to visit a primary care provider. Our LVNs contacted them and asked them, told them that they were available for lung cancer screening, eligible. Would they want to speak to a provider or lung cancer screening specialist about shared decision making? And if so, schedule them for exam and go through results. So again, slides are messed up, but this is our team of LVNs, and this is our group of APPs who actually saw these patients. But again, we have to have a idea about access. And so what we didn't want is to disrupt the access to the cancer center by having a lung cancer screening brick and mortar clinic. So the idea was that this would not be brick and mortar. This would be purely digital Davis virtual visits. So all these lung cancer screening visits were virtual visits. And again, this is Jennifer Allred, one of our NPPs, and trust me, there's a cool graphic behind here. Dan, what the heck is going on here? But this was supposed to be a telehealth slide. So this actually looked at all the different usages of telehealth within the different disease lines within the cancer center. And actually, believe it or not, for the entire cancer center, our telehealth usage is about 30% of encounters, which is actually an NCCN soft goal for NCCN member sites. The lung lead clinic was 100% telehealth usage with 0% telephone encounters, which are the lower billing entities. The lung lead clinic also saw incidental lung nodules and also masses that were suspicious for lung cancer but had no diagnosis and were therefore thought, well, perhaps we don't need to plug these patients into our thoracic surgery clinic and our medical oncology clinic and taking up access. Perhaps the lung lead clinic can do this. So again, our APPs help run that, and then also to provide them with some supervision and the ability to escalate complex patients who need more complex assessment. We had Dr. Aaron Noren, who's the Assistant Director of Division of General Internal Medicine Cancer Center Initiatives, who was also is also a key team member of that lung lead clinic. We also, as we talked about, that navigation piece and component. So that include Angela McKee, who's our nurse coordinated patient navigator, and Shalini Paul, who provides that what we call provider plus one care. So if a patient needs to see individual pulmonology for a lung biopsy, who can facilitate to make that happen quicker? If they need a radiology, MRI or CT scan, and it's taking a long time, who could really bug the radiology scheduler to get that moved up? So that was a key component. So this is the evolution of lung cancer screening at UC Davis Health. So the pre-existing state, the primary care physician-driven model, UC Davis had about a 4% screening rate. With Dr. Shack's group in his Clover study at Carmichael, a 25% screening rate. And all the patients touched by our lung lead clinic LVNs and navigators and APPs, a 53% screening rate. So this is some of the lung lead clinic successes and early numbers. So this is our percentage of patients agreeing to lung cancer screening since this started in August 2023. So 7 total patients. So 111 low dose CT scans, or 111 screening tests. With that, 7 total patients diagnosed with lung cancer through the lead clinic, 4 patients diagnosed through incidental findings, and 3 patients diagnosed through screening. So about 1 in 3.5 scans. One in about 35 scans led to a lung cancer. That's a pretty high concentration, and that's probably statistical noise. Oftentimes when a screening program first starts, you do have a high rate of screening targets. That generally is because of provider bias. So they'll take the patients with the highest tobacco dose exposure and refer them to screening. And so therefore you get a high rate. But it's interesting, this is a high rate of found scans. And then all the patients who were diagnosed with either stage 1 or stage 2. So this is some of our downstream results. 6 patients referred to thoracic surgery, 10 to interventional pulmonology, 1 to med-onc. There's rad-onc in here as well. And then you can see the PET scans, MRIs, subsequent CT scans, and et cetera. So again, in the United States, the screening rate is about 4.5%. In California, it's only 1%. We're last in the United States. I think the American Lung Association looked at this. We're number 51, so we're behind the District of Columbia. They didn't include Puerto Rico or Guam or American Samoa in that. UC Davis Health historically is 4%. And then we talked about those insurance issues, the ASCO survey that looked at insurance delays. And for the lung lead clinic, the average authorization time was 24 to 48 hours. Again, this is Dr. Noren here. Somehow the slides were mixed up. But this was an example of a incidental lung nodule that came to the lung lead clinic. You can see this picture up here, that little tiny nodule that was there. This patient was sent to our lung lead clinic and managed effectively by our APPs. Their APPs have a defined clinical pathway that was designed partially in NCCN guidelines, partially based on what we do here at UC Davis, put together by pulmonary medicine, thoracic surgery, radiology, radiation oncology, and other stakeholders, and followed by our MPs in the lung lead clinic. Expedited diagnosis and treatment, surgical resection for non-small cell lung cancer. This patient was discussed in a multidisciplinary tumor board and effective navigation by our lung ISO nurse navigator and our MA. So, so that's our first component. The second component, as we discussed, is the comprehensive patient navigation and care coordination. This is an interesting study done by MGH and Northwestern. They had what's called a lung cancer strategist program. And what they utilized really high intensive APP navigation and a personalized care team for their lung cancer patients. And what they found was reduced hospital and provider visits and diagnostic studies. People weren't working in parallel, getting the same studies for different reasons. Do you really need this study? Is this really relevant? And they found, and they compared their pre-navigator state to their post-navigator state, and they saw a significant reduction in workup time from 26 to 3 days, surveillance decisions 39 and 12 and a half days, time to diagnosis 48 to 30 days, and time to treatment from 70 days to 40 days. And what we hope to accomplish with the comprehensive patient navigation and care coordination is to take this complex interaction and turn it into a more workable solar system. And I had a picture here of Shalini Paul and Angela McKee, so somehow it didn't come up. But that's our key navigation and care coordination team. So this is our in-work progress. This is what we hope to do in the future. One is, as we all know, we've gone through changes in the last couple of weeks in our healthcare system based on our financial situation to right size our workforce. And our lung cancer ISL was not immune to those changes. So we have taken that lung cancer ISL and folded it into the clinical operations and continuity of the cancer center. So really embedding our RN and MA navigation within the cancer center and many of the administrative components of the lung cancer ISL to offer that sort of right size support. What is our future state? Establishing a survivorship clinic. So, I do enjoy seeing my patients every 6 months for 2 years and once a year for 3 years for 5 years total. But I like to call those well baby checks because in reality, I get a CT scan and it's a normal CT scan. And most of the time we're talking about where do they go on vacation? How are their grandkids are doing? Or by the way, you have no evidence of disease. But it's important not to allow those patients to leave the ecosystem and put that on primary care because 20 to 30% of patients who are treated for early stage lung cancer get a second primary within 5 years. And so those patients should be in the system. But when we deal with limited access for our providers is a surgeon or a medical oncologist or a radiation oncologist, is their clinic the appropriate place to have that survivorship? And then there are other components of survivorship, such as mental health and well-being, nutrition, and et cetera, and physical therapy that it could be incorporated into a proper survivorship clinic. We're looking at artificial intelligence and natural language processing vendors to help us coalesce these incidental lung nodules that are found within our medical center and the ED. And we're looking at generative AI, non-patient facing, to improve clinical operations, sort of the back of office systems to improve those. And really, we're also looking to expand our lung cancer care initiatives into our VA system. We have a really good relationship with thoracic surgery in our VAs, in our Sacramento, Northern California VA, a really good relationship with pulmonary medicine and medical oncology and radiation oncology. And so we really have the components to fast track those patients into our system if needed to benefit from our clinical trials. And then, what is the future of integrated service lines at UC Davis? I don't have the answer to that. As Dr. Farmer pointed out, we were the first integrated service line. Breast cancer is another exciting integrated service line that's up and running and is in its early design phases. We have other non-cancer integrated service lines. And will the initial strategic vision for integrated service lines be the point B of UC Davis Health? I don't have an answer to that. That being said, we could take the lessons learned from what we've developed so far in integrated service lines and disseminate those best practices to other cancer center service lines that are not quote unquote integrated, but are part of our traditional comprehensive multidisciplinary setup. And one is to increase access to some of our impacted service lines. So this is a pilot that we're doing. It's a pilot triage process called the Rapid Access Clinic. So this is taking the model of the lung lead clinic and translating it to other systems. And we're piloting that with lung cancer ISL as well as breast as well. So a nurse coordinator and their physician partner receives a referral. Our hope is within 24 hours or one business day to communicate with our patient service representative, the individual the administrator who does our scheduling triage with scheduling instructions. A provider's identified and that person is slotted into their clinic spot. If a clinical provider slot is not available within 7 business days, then that patient is then scheduled into the Rapid Access Clinic, which is populated by APPs as that initial touch point to get the ball rolling. What tests can be ordered? What referrals can be made? What patient education can be done? How can they activate that patient to their own care? And that Rapid Access Clinic, just like the lung lead clinic, will be based on virtual visits, not brick and mortar. These are some of the KPIs, key performance indicators that we would look at for this Rapid Access Clinic. Triage algorithms began in March 2024, and this program was initiated with a soft roll in late April with plan to monitor 2-month outcomes. We're looking at what percentage of our triage had 24-hour communication for scheduling and what percentage ended up in appointments less than 7 days. Not relevant for surgeons, right? Because our revenue generation is entirely on surgery, right? Surgery engulfs what's called evaluation and management billing. So that billing that's done in an ambulatory setting. But for perhaps a medical oncologist, could we be taking away revenue generation opportunities from our medical oncologists with this Rapid Access Clinic? When we looked at our billing and compliance teams, their assessment was no, because we maintain the complexity of the E&M billing for our providers. But that being said, we are going to be measuring E&M billing to make sure we're not putting our providers at production risk. And then we will compare this to our institutional key performance indicators, where a patient needs to be scheduled within 5 days, an appointment needs to occur within 10 days, and look at the median days to schedule and the median days to appointment. And also, we hope to take the lessons learned from our experience at the lung cancer ISL and then disseminate them statewide. Again, I don't know why these slides have come out this way, but we have what's called the University of California Lung Cancer Consortium. And so what that is a I like to use the word confederation, but I was told that I probably shouldn't use that word. but it's a cooperation and collaboration of our five University of California NCI designated comprehensive cancer centers. Our hope is to include UC Riverside at one point, but right now we're looking at UC Davis, UCSF, UCLA, UC San Diego, and UC Irvine. And we meet once a month to look at lung cancer screening best practices, and we're creating a standard of work for all of our five UC campuses. And this has become a statewide initiative to increase screening throughout the state, not just lung cancer, but breast cancer, colorectal cancer, prostate cancer, and more. And that's called hashtag UC Screen California. So for all of you who still use Twitter or X or whatever it's called, hashtag UC Screen California. So in summary, lung cancer care in the United States is inefficient. However, there's an idealized state of lung cancer care at UC Davis to fight that inefficiency. And the lung cancer ISL, as we have designed it, as we have identified those inefficiencies, provides patient value. And then the lessons learned can be brought to other cancer service lines. So again, thank you for your time, and I'm more than happy to answer any questions. Apologize for the mumble of the slides there if some of those images didn't make sense.
So thank you, Dr. Cooke. That was a great rundown, not only of the magnificent work that's been done in terms of improving screening in lung cancer, not just here, but around the country. This is definitely new awareness. So I just think, a decade ago when I was thinking about these things, lung cancer was way down on the radar, if you will, for screening. So I have two questions before we open it up. One is about screening in general. Why don't we do more of it? Why doesn't everybody get a screen? And why do we, I see Dr. Serene coming to the microphone, why do we do colorectal screening every 5 years instead of every year? I mean, it just seems silly, right? Wouldn't it be better to diagnose everybody early? So that's the first phase. And the second phase of that is we get lots of tests, x-rays, for other reasons in our healthcare system. So we get trauma x-rays, and I know we did a really good job of trying to get incidental adrenal findings looked at specifically in our films there, but we get, all kinds of things that probably image the lungs at some level for other things, whether it's breast cancer or et cetera. So how can we integrate those two things? So why don't we screen everybody all the time? We'll just walk through PET scans while you're coming to work. And why do we, or how could we better use the imaging we already get?
Sure. So why don't we screen everybody for everything? There is a startup that kind of hit the news about a whole body MRI and then MRIing the whole patient. And, the startup bros were, the tech bros were like, this is why healthcare is broken, because we could screen everybody and find something. The issue is sort of incidental findings. And as I tell patients, as I read the report, they find there's some weird thing in the spleen or something like that. It says, we have stuff that happens all the time in our body that means nothing, but we just don't get scans every single day. And that's why there's a complex component of lung cancer screening that's required to get reimbursement by Medicare, which is called shared decision making. And so if Dr. Serene could attest, if he wants to do a colorectal screen on a patient, you could just do it, right? You don't have to document that you talked to the patient about the pluses and minuses and the risk of colorectal screening. We have to document that we talk to the patient the risk and benefits of lung cancer screening, and including the risk of false positives and what can happen with that. And if we ever get audited by Medicare, we have to look at every single low-dose CT scan to see if there's a link to that shared decision-making conversation. That is burdensome, but I actually kind of one of the few people who actually kind of like it, because I think it helps with appropriateness of care. how to operationalize that has been challenging, and who does that shared decision making. It's a billable encounter, and so that's why we have our APPs. Uh, 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 our APPs do it. So why are more appropriate people getting screening? And I think that is related to our sort of culture, as I talked about before. I think breast cancer screening, colorectal cancer screening is on the zeitgeist. When I go see my primary care physician, I think I took some pictures of this. I'm sitting there waiting for her. I look at the little bulletin board and I see a nice advertisement for colorectal screening, a nice advertisement for breast cancer screening, a nice advertisement for STDs, right? Um, but nothing on lung cancer screening. In our own cancer center, I see a bulletin board about, I think it's colorectal screening, right? But nothing about lung cancer screening. Um, so how do we treat that? I'm a big believer in patient-centered work, and so patient activation. So we advise patients to say to their provider, am I eligible for lung cancer screening? And put that provider on the spot. We're a hybrid program. We haven't taken screening out of primary care, but if you so choose, we can control screening on our end and ask patients who are about to meet their primary care provider if they want to be screened. So that takes it out of the hands of the provider, the primary care provider, and puts it into an actual algorithm. In regards to incidental lung nodules, yes. So we're looking at similar to how our vascular surgery colleagues have really moved the needle on aneurysm detection here at UC Davis. We're actually want to follow their lead and look at AI and NLP to identify all these different scans that come in and find those patients who have nodules and plug them into a system. But if you all find an incidental lung nodule, you could either call us as thoracic surgery, or you could refer them to the cancer center and specifically requesting the lung lead clinic and sort of the other referrals.
Thank you. Thank you. We don't have shared decision making, but we have guidelines of our societies, and the insurance companies then follow those guidelines. So, for example, our initial low risk screening rates went from age of 50 to 45 a few years ago. It took a few years after that for insurance to cover that, and so now we can start screening at 45. And then to answer your question for colon cancer, I mean, we don't do it yearly because you have to find a balance between a value of doing the screening tests every year versus what you can detect. And so the balance is different for different screening tests. For colonoscopies, you can do one every 10 years if it's completely normal. For Cologuard, it's every 3 years. So it depends on what value it can provide in terms of finding patients. The question I have specifically for you, and I've been wondering about this since I came to UC Davis, is and the ISL shows that because the tremendous amount of work and design that went into it is very commendable. But you would think that the really low hanging fruits are not in place. For example, the survivorship clinic is, we analyzed this when I was at UCSF, and it pays for itself because when the patients are followed in survivorship clinic, all the scans that are ordered as part of the survivorship guidelines essentially pay for all the facility fee and pay for the NPO, whoever's manning that clinic. And so I wondered why that's not in place here if access is such an issue at the cancer center. And I'm surprised that despite a huge amount of work that went into creating an ISL, that's the piece that was difficult to put in place still. Can you try to
Yeah,
expound on that, please?
yeah. So yes, the cancer center does not have a formal survivorship clinic as we would envision a survivorship clinic to be. So a survivorship clinic isn't just, hey, how you doing? You're still alive. Great. That's great. It's more comprehensive than that. Um, why don't we have that in the ISL? It's baked into the ISL as a plan. Um, I was recently on spring break in Barcelona, and there's like this big church in Barcelona that they've been building for, I don't know what, like 300 years.
Yeah.
And so they've built the first two components, and then now I said, oh, good, now we can move on to the third component, in century number three. Um, so the best way to eat an elephant, yeah. So the best way to eat an elephant is to take a bite, right? And so we looked at what can we get running fast, right? Because as you know, we're not, our AMC is not unique. I know we feel, oh God, such pain, such suffering, but you go to other AMCs, it's the same way. And so when we looked at sort of the initial planning phase of the ISL, I think some of us realized this this energy is on the clock, and we have to get something off the ground, get a success, feel good before the energy runs out, right? And so, what can we get started first? Because we had again Dr. Shack's blueprint, and we did have a comprehensive lung cancer screening program, and this brings patients in. So it was that. And then where is the greatest need? The greatest need is the delays, the provider plus one, where someone has to see multiple people in the team falling through the cracks. So then the navigation component was next. And then we got this up and running. I could say that there was a member of our team who, pretty influential, um, was we have to have a mobile screening van. We have to have a mobile screening van. And I knew, that's like, picking your teeth after eating the whole elephant, right? And so that we pushed that down. Survivorship at the cancer center is from a clinical operations hat. That is something that we are looking to do. And I may be reaching out to you to kind of get your thoughts on the matter.
Thank you.
Well, we're at time. Do you want to ask a quick question, Ian, before we? This is such an important one. People will have to go.
Just real quick. So on trauma, we screen a lot of patients all the time. Are there missed opportunities as far as referring some of the patients that we get with nodules, or how good are we at getting those patients over to your system?
Yeah. I don't know how good you are. I think anecdotally, I get a lot of communication from trauma. Say, hey, we got a lung nodule. What should we do with it? So that's good. Hopefully, the AI NLP will take that out of your hands. But if you do find a lung nodule, you can reach out to thoracic surgery or refer directly to the cancer center, and then in other put lung lead clinic.
Great quick little study that can be done. Anyway, Dr. Cooke, thank you again. Great.
Thank you.